I would like to call our chief guest, Professor Azaz Khan, ex-HOD of Department of Medicine from Saidu Teaching Hospital.
Professor Aziz Khan Sahab, he's ex-professor of HOD Department of Medicine, Sedu Teaching Hospital, current principal, Swat Medical College, Swat.
Please come, sir. Coming to our next presentation on the management of acute kidney injury, I would like to call Dr. Mazharulhaq, Assistant Professor in Nephrology Department in Institute of Kidney Diseases, Peshawar.
Bismillahirrahmanirrahim. I welcome you all for this session, and I'm here to talk to you about the management of AKI. The time is short, so we'll just give you the brief overview because it's a huge topic, cannot be covered in 15 minutes. So we'll just the general management of the AKI. So first we will have to, what is AKI? It's an abrupt and reversible decline in the GFR, due to which there is an elevation of serum blood urea nitrogen, creatinine, other metabolic waste products that usually normally excreted by the kidneys. And if it is associated with reduced output, if the patient become oliguric or anuric, the volume overload may result. A very busy slide, but again it's very important because before going for the management, first you will have to establish the diagnosis of AKI, and then you will have to stage it as well. So AKIN, Acute Kidney Injury Network, and KDIGO, which is Kidney Disease Improved Global Outcome, they provide you with the definition of AKI, and according to them, we usually follow the KDIGO. So according to them, the serum creatinine are more than 0.3 milligram per deciliter within 48 hours, or if there is an increase of 50% within the 7 days, or if the urine output of less than 0.5 ml per kg per hour for more than 6 hours. So it is mainly based on the serum creatinine and urine output. If it meets the criteria, you means that the patient has AKI. And then you will have to categorize it at stages as well, because the more the advanced stage, the more are the complications. So in stage 1, if there is increase of serum creatinine of more than 0.3 milligram per deciliter, or 1.5 to 1.9 times baseline, or if there is urine output of less than 0.5 milligram per hour per kg per hour for 6 to 12 hours. So 6 to 12 hours and less than 0.5, 1.5 to, so this is stage 1. If the patient has the urine output, now the creatinine has gone up to 2 to 2.9 times the baseline, the urine output of less than 0.5 for duration has been increased 12 to 24 hours, so means the patient is in stage 2. If the serum creatinine is more than 3 times the baseline, or if it has been increased more than 4 milligram per deciliter, and now the urine output has further reduced to 0.3 milligram per kg per hour for more than 24 hours, or if the patient become anuric for more than 12 hours, means that he is in stage 3. So this is the stage where you will initiate renal replacement therapy as well. If the patients come to you, what you will do, you will have to systemically evaluate for immediate threats and complication. You will have to assess for the severity of AKI, and then you will have to identify the cause and treat properly. So the KDIGO stages the severity from mild to severe. And the complications are more severe and life-threatening with more advanced stages of AKI. Usually it depends upon whether the patient is inpatient or outpatient, but usually we receive the outpatient. So initially evaluation of the patient is very important, because you will have to triaging the patient for management, because some patient you will have to refer to emergency department, some for nephrology refer, and some you will send home. So you will have to identify patient for emergency department referral, and we refer the patient to emergency department if the patient has stage 2 or stage 3 as per KDIGO criteria. Stage 1 को तब refer करेंगे if the patient has unclear etiology, if the one that cannot be reversed with simple interventions like postnatal AKI, or in the presence of agar a patient has other comorbid condition like the patient has CCF, or if there is diagnostic facilities are not available, so in that cases you will have to refer again to the emergency department. Then there are patients that do not need referral to emergency department, but they need urgent referral for nephrology. If the initial intervention failed to improve the kidney function, and if you are suspecting another diagnosis like GN, that needs workup, renal biopsy, all these things is needed. So then you will have to nephrology. Or if it occurs as a complications of unrelated condition and the future treatment depends upon nephrology input, like the patient has received chemotherapy for some other illness, now the patient has developed AKI. So this patient needs to be referred to nephrology. These are the absolute indication for dialysis. If you see a patient with these complications, in that cases, these symptoms, signs, so you will have to go for urgent dialysis. So these are the absolute indication. If you are a patient with a pulmonary edema, if there is severe hyperkalemia, if the patient is uremic, the patient has uremic symptoms like pericarditis, nausea, vomiting, CNS symptom, in that cases you will have to go for dialysis. Or if there is hypervolemia along with them, it's severe metabolic acidosis with pH of less than 7.1, and in acute poisoning cases you will have to go for renal replacement therapy as well. If the patient are oliguric and hemodynamically stable, then you can try 80 to 200, not in uric patient. If the patient oliguria of less than 500 ml, and urea means less than 100 ml per 24 hours. So if the patient is oliguric and hemodynamic stable, you can go for the 80 to 200 mg of IV furosemide. First try the 80 mg, if you didn't get the response, make it double, and up to 200 mg you can go. Beyond that you will not go, because itself is notorious for causing tubulointerstitial nephritis. If the patient has already received the low dose, you will have to give them double the dose. And how you will assess for the adequacy? If you get a response of more than 200 ml within 2 hours of furosemide dose, it is 1 ml of urine for 1 mg of diuretics. So if you are giving 80, you will expect 80 mg of 80 ml of urine. If you are giving 200 mg, you will expect 200 within the 2 hours. But if the patient is not responding to all these things, you will have to go for renal replacement therapy. If the patient has potassium of more than 6.5, severe hyperkalemia, with signs and symptoms of hyperkalemia like muscle weakness, or if patient conduction abnormalities, ECG changes are going, so in that cases you will have to go for urgent dialysis. Along with that, rapidly acting therapies, he will have to receive that as well, like insulin, glucose, and at the same time hemodialysis. But you will consider hemodialysis in these patients even if the hyperkalemia is more than 5.5, if there is ongoing tissue breakdown like rhabdomyolysis, or if there is ongoing potassium absorption, for example, significant GIT bleeding. Again, life-threatening uremic symptom, in these cases you will have to go for, and these include CNS symptoms, GIT symptoms, and cardiac involvement as well, like in the form of pericardial effusion, pericarditis. Toxin, if the patient has toxin exposure, any toxin, methanol, ethanol, lithium, acetaminophen, in that cases you will go for dialysis as well. This is acute, then comes the subsequent management. Now you will have to identify the etiology, and then you will have to treat it as well. Any reversible factor like hypotension, volume depletion, or obstruction, you will have to relieve these things as well. And remove any active insult to minimize new injury. And then you have to identify and treat the complication that may eventually require renal replacement therapy at the later stages or later period of time. So you will have to stop all the medication which are nephrotoxic. These include ACE inhibitors, ARBs, NSAIDs. Nephrotoxin includes this include antibiotics, piperacillin, tazobactam, aminoglycoside, even amphotericin, antiviral like tenofovir, and chemotherapeutic agent as well. Some drugs are renally cleared, so then you will have, but they have serious adverse effect with accumulation in the setting of AKI. So either you will have to avoid it, discontinue these drugs, or modify the dose, adjust the dose. Then, if the patient is hypotensive, like low systolic, diastolic, due to any cause can precipitate AKI. So in this case, rapid identification, evaluation, and correction is very important to prevent further damage to the kidneys. Intravascular iodinated contrast agents should not be. You should not go for iodinated contrast agents, but if it is needed in emergency, like the patient has an MI, they are going for primary PCI, so go for it. If the patient, you are suspecting aortic dissection and you need that, so in acute emergency cases, you will have to go for that. Otherwise, it's contraindicated. But dialysis, अच्छा दूसरा ये है कि it should not be routinely performed to mitigate the risk of further injury. Just contrast removal के लिए don't go for it. But if you see that the patient renal function has been worsened after the contrast, in that cases you go for renal replacement therapy. Then you will have to assess the volume status of the patient and management as well, by clinically and by the inferior vena cava ultrasound, because either hypovolemia or hypovolume, that should be corrected. Hypovolemia, if it is consistent with the fluid loss or physical examination consistent with hypovolemia, you will have to correct it, because your goal is to increase the cardiac output and improve tissue oxygenation in patients who are pre-roll dependent or volume responsive. This is just to prevent for ATN, okay, ischemic ATN. So how you will go for hypovolemia, 1 to 3 liter of crystallide with assessment of clinical response. If you see that the patient has, the output has been increased, the creatinine is going down, and the clinically the patient is improving, so then you will have to continue with isotonic saline of 75 ml, more 75 to 100 ml per hour. There's control hydration. But it should be reduced if the patient has effective blood volume, like in patient with cirrhosis, in that case, the effective blood volume is decreased. Our older patient, it's very difficult to assess the dehydration status. So in that case, a small volume should be tried, 1 liter. But if the patient doesn't respond to all these, then you will have to think about other things, that the patient has developed ATN, the patient has developed tubular interstitial nephritis, or some GN is going on. But in some condition, you will have to go for more vigorous fluid resuscitation like pancreatitis, rhabdomyolysis, and tumor lysis syndrome. And do not use colloid solution for treatment of hypovolemia in patients with AKI. Crystallide देंगे. If you are receiving, a patient can go into hypervolemia because of so many reasons, that he's receiving IV fluids, blood products, FAP, platelets, all these things is going, especially in sepsis management and especially in patient ICU. So all this leads to hypervolemia. So here the role of diuretic, if the patient is hypervolemia and not anuric, if the patient is only oliguric, go again with the ATMG, then you increase, you will assess for the response within 2 hours of the diuretic, the double the dose. If you didn't get the response, then lack of response, then you will have to go for fluid, extracorporeal ultrafiltration or extracorporeal removal of the excess fluid. Only the kidney replacement if the patient is anuric for more than 24 hours, fail to respond, or whose response diuretic is insufficient. How you hyperkalemia? Again, it depends upon the etiology, clinical manifestation, and the effect of medical management. And there should be a potassium restricted diet, less than 2 grams per day. And at the same time, it directly antagonizes the membrane effect, driving extracellular potassium into the cell and removing excess potassium from the body. Dietary phosphate, restrict the dietary phosphorus to less than 2 grams per day in all patients with AKI, except the patient with hypophosphatemia. These are few indications of phosphate burden, but there is no consensus on that, so we'll avoid that. You will have to look for hypocalcemia, hypomagnesemia, hypermagnesemia, and hyperuricemia, and you will have to treat that accordingly. Acid-base balance, like the patient metabolic acidosis. So in the patient has severe metabolic acidosis and the patient is oliguric or anuric, you will have to go for dialysis. But if the patient has metabolic acidosis and not in volume overload, you can try bicarb. Your goal is 22 milliequivalent per liter, and the pH goal is more than 7.2. This is the managing nutrition. This is the most neglected part of the management of AKI, because these are hypercatabolic state, usually these patients, and they need approximately 25 to 30 calories per kg per day. And proteins energy wasting is very common in these patients. So if the patient has mild to moderate illness, they require 0.8 to 1.2 gram per kg per day of protein. And the patient in critically patient on hemodialysis, the requirement increased to 1.2 to 1.5 gram per day or more. It may be in parenteral form or enteral form. Then you will have to monitor these patients for with the serum creatinine, electrolyte, ionized calcium, total serum calcium, and phosphate on daily basis. But if the patient is needing calcium supplement, if the patient is needing bicarb therapy, in that case, twice per day should be monitored. Potassium should be checked more frequently who have elevated serum potassium on presentation or who are oliguric or hemodynamically unstable. You will have to monitor daily weight, fluid intake, and urine output in order to assess the daily fluid balance as well. Patient with moderate to severe AKI should be closely monitored even after discharge from the hospital, regardless of the extent of their recovery, to guard against the recurrent AKI, development of CKD, end-stage kidney disease, and cardiovascular events. And these moderate to severe AKI should have outpatient nephrology evaluation. If that is not available, then primary care physician shortly after discharge. With that, I thank you.